He's a 77 years old male. He's suffering from a trauma. He fell down at home and fractured his pubic. And also, when he was studying, they found a huge iliac aneurysm. He has history of hypertension, heavy smoker, alcoholism. He has liver disease under investigation here by our colleagues in the hospital. He's a patient with potential cirrhosis, but still not confirmed. And he has suffered due to this fall pelvic trauma. And as I told you, multiple fractures there. So this is the angio. So it's a huge iliac aneurysm with calcifications on the beginning of the common iliac artery, almost no proximal neck to treat only this vessel. Next. The abdominal aortic measurements I already did in the morning is 11 centimeters from the renal arteries until the carrefour. The diameter of the proximal aorta below the renal is 21 millimeters and 30 at the, near to the carrefour. Next. And this is the right iliac artery. The common iliac artery diameter is 15. We have another measurements which is a little bit bigger, like 18 or 19. That's why we are going to use a bigger branch there. The external iliac artery is also huge. I think measurement is 11. Next, and excuse me, the length of the iliac artery, the common iliac artery is 7 centimeters. Next. So this is the huge aneurysm on the left common iliac artery with almost no proximal neck, which is also dilated. It's 18 millimeters there, so it's almost impossible to get the correct sealing if we use only a device to cover this aneurysm without treating the abdominal aortic bifurcation. So the aneurysm extends until the bifurcation involving the ostium of the hypogastric, and then there is a normal external iliac artery. Our strategy is to do a bifurcated EVAR device with the previous left hypogastric artery embolization. We have planned to do, actually, we have already done a percutaneous femoral access. We called our colleagues here for surgical standby, just in case we have bleeding. Coils embolization for the left hypogastric probably would have been easier and faster to do a plug embolization. But, you know, once again, we have to deal with health insurance here. So we don't have coverage for a plug. So we have to use coils. And then a bifurcated EVAR prosthesis extending until the external iliac artery on the left, just to cover all these huge aneurysms. Just to let you know that in many cases, we have tried different solutions for that. We have used cover stent, self-expandable stent, balloon expandable stent, and even in one case, we have implanted one stamp of the EVAR device from contralateral side, so that we have the huge part in the beginning of the aneurysm and the smaller part on the external iliac artery. All what we have tried, to be honest, I would like to tell you that it's not a good solution in the long run. That's why when we have huge iliac aneurysm with short, less than 20, or I would say less than 25 or 30 millimeters in length of the proximal neck, we would rather like to go with a bifurcated device to be sure that this is going to be a complete sealing for the follow-up. So once again, I have to hold this part of the device on the right orientation. So we have the contralateral stamp orientation to the left. So I am going in. It's very easily to advance. Then, okay, move para allá. Okay, these markers are showing you where the graft starts. And the proximal part is the fixation stent. And please zoom. Vos, Claudio, zoom. So here, for those who are not familiar, we have like sign that when we have a check sign here, that it means, or it shows you that the orientation of the contralateral stump is correct. Additionally, Dr. Fava is going to test the renal. I have lost the position of the renal test, so we are too high there. Remember that in this case, necks is very long. There is not problem with short necks. So I'm going to be below the renal. Test again. Be sure. And there, the contralateral stump is released, and it's perfect on the other side. There, it's important to see on lateral views. So to be sure you are pointing, it's better the straight wire. I don't know why Matthias gave me this angulated wire, but I don't like for this, especially when you are in a hurry. No, let's go to the other, a la izquierda. Okay, let me see. This is probably the more difficult part, although especially when you have small aneurysm, a small aorta. I think I am in now, although I am using the enemy's wires. Now I have to be very careful not to lose in the position because there is angulation there. Let's go frente, Claudio. So here I had to rotate the catheter because this wire is doesn't have enough support. Anyway, I'm sure I am in. This is important to check that you are inside the body before introducing stiffer wire and not in parallel. So let's go up, Claudio. So now I have to release the security of the proximal cap. I am releasing this wire, which is for secure the proximal fixation system. And now I open here, I'm pushing here, I'm gonna deliver it. You will see how the proximal part of the stent graft is gonna be open. I will leave it there, up, just in case of any movement. I'm not moving the device. Why we should embolize this artery in that's a huge aneurysm? Because if we put the cover endograft going from the main body until the external iliac artery, when you perform the injection, you will only see the contrast media going in this inside this stent until the external, and you are not going to see anything else, and probably you're going to be very happy with the outcome. But then you are going to have flow back from the hypogastric artery until the aneurysm, filling the aneurysm, pressurizing, and keeping the risk of this aneurysm rupture. So you have to close these arteries always. If not, the aneurysm is not completely sealed. So you see, I have at least 2 or 3 centimeters there. I'm gonna release completely and there. And now we are going to prepare the second branch. So there is not, we can use an introducer here, a big introducer, but these branches are 14 French. If I put an introducer, it should be 16 or 18. So I would end up with a big hole here on the left comoral axis. So I would rather like to stay sheetless, or actually using the sheath of the device. But this stump can go into the main body sheath, but it's not possible to put the second stump through this sheath. I have to exchange everything. So once again, Juan is gonna hold the groin. I will pull everything out and introduce the second branch. So I think the time is okay. You have a second question. Well, for when you have tortuosity, Landerquist is the best wire to use for sure. In the cases like this, I thought from the beginning that the implants would have been okay. I don't know why I have this resistance to go in. The other is to catheterize the contralateral orifice. You have to use the CR4, the Lima, the implants, or sometimes you have to try many catheters. In the worst situation, you have to go from brachial or humeral or radial or whatever superior access to snare a wire, to pull it, and to introduce the wire inside this orifice. But it's really uncommon, because if you are patient, you can do it. What is important for this contralateral orifice catheterization is to prevent, to deliver this stamp against the border of the aneurysm. What I mean is, if you have an aneurysm, something like this, and this stamp is gonna, it's gonna finish here, it's gonna be impossible to go here and then into this orifice. It's better to introduce the device from the other side. I don't know if I am clear enough. So here, I am not sure. This is the minimum overlapping I have to do. And I think I am distally enough into the external iliac artery. The wire you see outside is the wire protection we have from below. Yeah. Now, Carlos is gonna push the wire a little bit. With Landerquist, you have to be very careful about not kinking. Okay, so I'm gonna help you. I'm gonna pull and you introduce wire. Combination, combined maneuver. Being very careful of not kinking the wire, because if not, you are going to lose the position. Now we can balloon in here. Probably we can use the Coda balloon to, try to get a better contact with the artery wall on the external and also on the joining, or I would say connections between main body and the first stamp, and then the connection between the two stamps. The areas of overlapping where it's very easy to see on the floor. So this is a highly compliant balloon. The Coda balloon, you have to inflate. There's a sensation. There is not pressure. It's a sensation that you have that you are inflated enough to get a good contact against the artery wall. So I would like to ask for more questions or comments. If you have, if anybody in the audience would have chosen a different strategy, here is important to let somebody knows to be here and to hold here. Because when you are pushing the balloon, sometimes you lose the position and this hydrophilic sheath goes out. And this is not good. So here, probably the position is not that good because it's moving. The other question probably is why we are using regular Zenit device and not the alpha. In this patient, probably it's not too much important because he has huge arteries. The alpha device is a very low profile device. Here you see I have problem there. So probably I would have used another balloon, probably low profile balloon. Give me a balloon de 10. Yeah, you see, I have problem to advance there. So Carlos will retrieve it. So we inflate there with a 10mm balloon. Probably we have a kink in there because it's in the middle of the aneurysm. Okay. Please prepare this. For this balloon, we will need an indeflator. Okay, we still have 25 minutes. Please go as fast as you can. Let me check where we are distally here. I think we are not distally enough. We might need another. I think we still have blood flow into the aneurysm. So probably we should use another extension. Yeah, you see, this is the problem. So we will put another extension. Yes, a 13/64. So before inflating there, I'm gonna fix. This is the reason why the distal ending zone was moving, because was exactly at the border of the aneurysm. Could have been a little bit distal my implantation? No, because I wouldn't have done enough overlapping. So without the good overlapping, probably it's not a good idea, because when the aneurysm is completely sealed, then with the shrinkage, hopefully I say okay, it's gonna decrease the size, and then it's gonna change the orientation, and we might lose the position if we are not distally enough. I'm gonna push the sheath, because if not, we in any movement we can lose the position again. Let's inflate once, and then let's go with why Juan is there holding from here. I'm here because if this sheath moves out, we are going to have huge bleeding. This introducer, the valve is not that good as the other introducers, so you might have some bleeding as we have here. Sorry for that. So now, Carlitos, retrieve the catheter and leave the amplifier there so that we can introduce the pigtail. Any other question, Andres?
Yes.
Okay, great. Yeah, the surgery was considered, but remember he has a significant hepatopathopathy, probably a cirrhosis. The patient also has this orthopedic problem. So surgeons were a little bit reluctant to operate him, having the chance to do this endovascular procedure. Okay, 25. Okay, give me a second to see where is the pigtail.
Sorry.
Okay. I don't know where is the pigtail. It's so obvious that catheters are not too easy to see. So we have to aspirate because both iliac arteries are almost occluded, so we are not going to have distal flow.